All right, we'll be getting started in just a few minutes. All right, so good morning and welcome to the Pinnacle Awards Innovation Pharmacy Lecture. On behalf of the APHA Foundation, I'd like to welcome you all to APHA headquarters again. Thank you also to our Board of Trustees and our APHA Foundation Board for your presence and support. So today it is my distinct pleasure to recognize someone that not only has made an impact in pharmacy, someone that's made an impact in public health. Our lecture today will be delivered by Captain Lisa Tonrey. But before I get a little bit into what she's doing, I do want to share with you that we are on Facebook Live. We'll have people tuning in, watching the video, and also asking questions. So throughout the presentation, we'll have actually Dr. Jing Wu, who will be coordinating our Facebook Live questions and moderating on behalf of them. So Captain Lisa Tonrey has demonstrated a 38-year healthcare leadership career dedicated to improving the health of the underserved and vulnerable populations. She possesses diverse international, national, and regional experience and expertise in healthcare administration, public health, prevention, emergency response, quality improvement, operations management, clinical and pharmaceutical care delivery, and consultation. She has national healthcare experience in policy development, healthcare management and operations, healthcare systems, accountability and population health management. She has clearly demonstrated national and international public health and pharmacy leadership experience as a career in the Public Health Service, commissioned officer, president and trustee of the American Pharmacists Association, and currently as a technical advisor at the U.S. Agency for International Development, Office of Foreign Aid Disaster. Please help me in welcoming Captain Lisa Tonrey.
Thank you. Thank you all for being here. So today we're going to talk about innovative roles of the pharmacist in population health. And so we're going to set some of the background pieces just so that way we have a platform to talk further. I'd really like to, at the end, just do my presentation and then really open it up for some good dialogue and discussion. And as we go through this today, I'd like people to start to think about some of the things that we're going to present. The disclaimer, I've retired from the U.S. Public Health Service. I presently work with USAID, Office of Foreign Disaster Assistance. I've spent several decades working in public health as a public health advisor, healthcare administrator, pharmacist, in my various roles. And in today's discussion, I am speaking on behalf of myself. Okay, so 100 years ago, the location is New York City on the Lower East Side, known as the Bowery. A little girl named Anna is 10 years old. She goes to school, she plays outside, she runs errands for the family, goes to the local market, and she starts to begin to notice something really disturbing. People she knew were being brought out of their apartments in boxes or on stretchers and being piled up on the side of the curb. This was happening daily. Neighbors she would talk to in the morning were dead in the afternoon. This impacted her view. So what was going on? 33%. 100 years ago, 1/3 of the world's population contracted Spanish flu. 100 years ago this month. What does 33% mean? That's 1/3 of the population. 500 million people were afflicted with the Spanish flu, which is also known as H1N1. Mortality rates were highest in 3 groups. So the groups you would predict would be the most vulnerable: children under the age of 5, elders over the age of 65, But what was really unique about this was that 20 to 40-year-olds, the otherwise healthy people, were still just dropping like flies. In 1918, I like this picture. Looks like something from a silent movie, but this is from the Library of Congress. This is a real picture of a lady she's an older teenage girl who contracted the flu. In 1918, there were no vaccines to prevent the flu. There were no antivirals to treat the flu, and there were no antibiotics to treat secondary bacterial infections. So mitigation of disease was really limited to non-pharmacological interventions such as isolation, quarantine, good personal hygiene, use of disinfectants, and limitation of public gatherings. In 1918, they closed the schools, they closed churches, and they wanted people just to stay home. Are we better off today than we were 100 years ago? Absolutely. So which information is more impactful? One person, 33% of the population, or 500 million? As we start to get into this today, I want to look at, from a disease prevention perspective, how we as pharmacists use data, how we communicate our value, and what our role is in population health. So let's look at this again. One patient, one person, one patient. It's how we always speak about patients, patient care. I take care of my patients, or I take care of a patient, or I give a shot to a patient. Percent of population. What does that mean to a pharmacist? And this is really, I'd like you to think about this. As pharmacists, are we looking at the percentage shots given that from the order, the total supply of what we have in the refrigerator? Or are we really looking at the percent of the community that we've served, or the percent of the community that we've protected from disease? Corporately, every retail pharmacy knows kind of their user pop, or that's how they, project where their stores are going to be. But the pharmacist on the front lines, do they ever consider this data of what their community is, who their community is, and how they serve them? Certainly, in terms of number of afflicted people, we focus in pharmacy on some of the non-communicable diseases where we do medication management. So we focus on, the disease burden in diabetes or hypertension, but how many of us really consider the numbers of diseases prevented? So 500 million people afflicted. Did this happen in the US today? Well, from a global perspective, sure it can. Let's go over herd immunity real quick. So this is a busy slide, but really what I want you to get from it is the color. Top slide, you have a few infected people in red with an unimmunized population in blue, and suddenly you have an affected community. In the middle box, you have a smaller portion of people who are immunized. They're in yellow. And those not immunized can become infected, or the red. But those in yellow will not contract the disease. Bottom box, a large population immunized in yellow, preventing the spread of illness significantly impacts or includes unimmunized people. So that's the herd immunity. The people around you who aren't immunized, when you have large numbers immunized, will be protected. And so we need basically 84 to 93% coverage rates to give protection. So let's go back to that question, could it happen today? In 2016, PAHO, Pan American Health Organization, World Health Organization, announced that the regions of the America eliminated measles. They reported that it was the 5th disease to be eliminated in the Americas. Less than 2 years later, we've already had close to 5,000 cases of measles reported in Venezuela, Brazil, Colombia, Ecuador, Peru, and we've had 107 cases up through August in the United States alone. Public health. So as I was doing my research for this presentation, I came across this slide. So this is a picture from 1941 of the United States Public Health Service. And if you're tired at night one night and want to look at something to go to sleep, you can look at this. But what's really kind of interesting, though, is it's the same issues. This is 1941. Here we are in 2018. It's still the same issues. But the big piece of what I want you to get out of this is that prevention, kind of the base of the tree, the trunk of the tree, really is the foundation on which all other aspects of healthcare branch out. So the pharmacists in the community are really poised to run with prevention strategies. So let's get into that a little bit more. So prevention, I'm just for definition purposes, primary, secondary, tertiary. So primary prevention is the prevention of disease or risk reduction to reduce the risk of disease in a non-diseased person. Give a shot, prevent a disease. Pharmacists do it. We're doing it all the time now. 10 years ago, we weren't. Okay, that's the easiest low-hanging fruit. Do something, prevent the disease. Secondary prevention would be identifying early diseases in its early state. Catch it early. We screen and we intervene. This is where we would be doing blood pressure checks or cholesterol checks or any kind of checks that are going on. And the pharmacists, I see that we have tremendous growth potential with point of care testing to be poised to do more screening. We can go into, let me give you examples of both. So in primary prevention, I also see what else could we do besides immunizations. Number one, we already know we're not immunizing. We're not up to the Healthy People 2020 goals for immunizations. So we could do a better job in immunizations. What else could we be doing? Just think about this and we'll talk about it a little bit later in terms of primary prevention. Give you a good example. Fluoride varnishes. It's one of my other passions. Fluoride varnishes can reduce the risk of dental caries, and tooth decay is the #1 disease, preventable disease in children. Yet most kids don't see a dentist before the age of 2, and that's when you can intervene, particularly in communities of underserved communities, and also in communities where there's no fluoridation in the water. They're most at risk. So what could we be doing in terms of applying fluoride varnishes? And I see fluoride varnishes as one of the next waves of things pharmacists can be doing at the point of care in a community pharmacy to help impact the community. Secondary prevention, we're going back to screening and intervening. Point of care testing. Let's give an example of that. Where we're developing, through collaborative protocols. If a patient came into your retail store, they had flu symptoms, you could test them for flu. And if they had it, you could give them Tamiflu for treatment if you had that collaborative protocol. If not, you could give them a flu shot and give them some OTC meds and send them home. Monitor it. Most people will go to a pharmacy before they will go to an urgent care or an ER. So we see those people all the time. What's the health of our population? Tertiary care, we do a lot. I mean, we're doing that with patient care. That's where we try to mitigate morbidity and mortality of the disease. They already have a disease. We're trying to slow the disease process down. That's where we, as pharmacists, have probably made the individual impact with therapeutic management. Let's look again. Let's look at this from a healthcare provider perspective. Who predominantly works in this space? So in primary prevention, pediatricians and family practice that work with young children, they're all about it. Breastfeeding, car seats, and vaccinations. That's pretty much the 3 things that pediatricians focus on initially. So although a lot of pediatricians will focus on getting kids to their goal before school age, then they start to drop off. Who's not working in this space? What about teens, young adults, and older adults? Who's seeing those folks and who's maximizing the opportunity to vaccinate or provide preventive services? Secondary prevention. who works in this space? Well, depending on the age group or the risk factors, most physicians will conduct routine screenings. You come in, they'll screen your blood pressure, they'll take your temperature, they'll take your pulse. However, how many of these people in the off, what I'll call the off years, maybe 18 to 50, how many people actually even go to see a doctor annually in those age groups? Women might, because they're usually childbearing age, or they have children and they're usually the healthcare providers in their home. But we have lots of people between the ages of really 18, even younger, 18 and 50, 18 and 60, 18 and 65, that really just don't go to a doctor until something happens. Tertiary prevention. So with high-risk diseases or lifestyles, the focus on mitigating morbidity and mortality is where they focus, right? So again, what's the opportunity to be working with men age 18 to 50 in terms of what we could be doing? So a tertiary intervention would be smoking cessation, right? They already smoke. They may already have, we haven't screened them for what other diseases they may have with that, but we can intervene in terms of providing a therapy for them. Here, let's move a little bit out of this, and we're going to start talking about public health versus population health. So there's a differentiation. The Institute of Medicine right next door says public health is based on it's based on policies, health education, outreach, and research. So it's what we as a society do collectively to assure the conditions in which people live can be healthy. Population health is a little bit different. It's working on improving health outcomes of the communities through collaborative efforts. And so if we get nothing else out of this lecture today, this is what I really want to drive home. We are poised as pharmacists to be working in improving health outcomes in collaborative effort in the community. So what strategies are we as a profession utilizing to improve health outcomes in our communities? What does the CDC say about population health? Well, they look at it as population health brings significant health concerns into focus. It addresses resource allocation, and it addresses systems issues that drive poor health conditions. So CDC views population health as an interdisciplinary, customizable approach that allows health departments to connect practices and utilizes non-traditional partnerships among the different community sectors. So I can't emphasize enough, what strategies are we using to enhance our non-traditional partnerships in the community, especially at the state level, where we can have the greatest influence? Institute for Healthcare Improvement says the next frontier of medicine for the next 10 years is going to be population health and population health management, population medicine, right? In developing new collaborations, in governance structures, skills, in new approaches, and also in addressing inequity in both health and healthcare. So let's take a look at what's going on in the current landscape of public health. So right now, in the public health and safety state-by-state public health funding and key health factors published in 2017, so just last year, core funding for health promotion and disease prevention has declined. Centers for Disease Control, which we consider the main organization for health in this country, budget decreased since 2010. State health departments' spending has remained relatively level with no expected increase in funding. And currently, there's a proposed 18% cut to HHS, which includes CDC, and they expect that CDC's anticipated spending rates will fall 16% below 2010. So even though they still have the health of the population to take care of, their resources are dwindling. So how else are we positioned to kind of step up to be that collaborative partner? And how do we strategically want to partner with these organizations? So state health departments, let's look at them specifically. We kind of looked at what's going on with CDC real quick. State health departments have a good sense of children entering kindergarten and middle school in terms of their immunizations. College age is a little bit trickier. They don't have real good data on that. Adult information could be a big challenge. They may not know that. And they rely on 4 to 5 year old NIS data for a snapshot of immunizations. NIS data is the National Immunization Survey, where they phone call parents and ask them if they got what shots their kids got, or if their kids got their shots. We're talking 2018, right? The data that gets published is about 4 years old, and it's collected in a way that's not even standard in the United States anymore. Anyway, state departments, by and large, are not receiving any new funding. They work with relatively small staff and are very physician and nurse-centric, going by the wayside of public health clinics. So they don't have a workforce. State health departments look at epidemiologic data. They don't know how to use, they don't know how to translate, or they might not even have access to claims data. So in a managed care setting, they're usually looking at claims data to determine outcomes. Public health departments look at the epidemiological data, and they don't have access to claims data, nor they really know what to do with it when they look at it. So if a pandemic were to occur, who would help them in addressing any of these gaps in a state? Whereas pharmacists, we could be one of their biggest healthcare partners, particularly in the realm of immunizations. And I know that they will be receptive to working with us. So let's look a little bit more. Vaccine coverage for adults. So this slide came from the APHA Foundation. It's based on the Morbidity Mortality Weekly Report 2016 and the Healthy People 2020 goals. So here we are in the coverage rates in the middle of where we are in 2016 for the various different immunizations. And 2020 goals, we're not even close. 2020 is in a year and a half. And if you look at fiscal year, the way the government goes, it's next year, because we start fiscal year 19, October 1. So how close are we? So if we don't do something different, we're never going to get to Healthy People 2020. We're not even going to be close. So what do health departments have? So every state has an IIS, an immunization information system. I'm just going to call it an IIS because it's a tongue twister. Not all of them are bidirectional. There's about 30-something states that have bidirectional information. That means information goes into the system and you can read the information back. Pediatricians in family practice that participate in the Vaccine for Children program must report. It was set up by the CDC for the Vaccine for Children program. Not all immunizers are required to report. At the point of care, an IIS can provide consolidated information about immunization histories for a vaccination provider. At the population level, an IIS provides aggregate data on vaccine use and can be used in surveillance programs and guide public health actions. So pharmacists, we must report in most states. In Arizona, all immunizations given by a pharmacist must be reported to the IIS. But other vaccinators are not required to report. So where do we go, or how do we look at getting data that's accurate and complete? How does the state do that? And I want to have a dialogue about that after this. So here's where we are. This is my favorite slide of the whole show. Power in numbers. What's 10K a day? 10,000 people a day. Turning 65 years old, and I'm getting close. Right? 65 years old, 10,000 people a day. Right? We already established the 65 and older population are the highest at risk, or the high-risk populations. 301 million visits every 7 days. That's the number of visits to a pharmacy a week in the United States. 301 million. Pharmacists they are the providers who see patients more frequently than any other healthcare provider. I don't know what all the doctor numbers are combined, but they're not seeing 301 million of the general population every week. 280,000 pharmacists, 397 technicians are a workforce. 280,000 pharmacists who are practicing, who are trained immunizers, certified immunizers. We're a workforce to be reckoned with. So from a population health management point of view, we have 20 million people who are at risk. They're over the age of 65 and older. We have 15.652 billion visits to a pharmacy annually. That's power in numbers, folks. 15.652 billion visits. The number of, it's equivalent, the population of the United States passes through the doors of a pharmacy once every 10 days. And 280,000, we're a workforce that's ready and willing, that can immunize. So we've got big data, we have really big numbers, and we have really large access. So let's not waste it. Let's use it. Let's talk about that a little bit more. Population health management, some of the opportunities that IHI says is aggregating all patient data from health information and resource technologies, using a single actionable patient record to inform providers. So I'm not going to address the HIE issues or initiatives that are going on here, the interconnectivity between medical records, but I do want to discuss some of the tools that are available and the use of an IIS or the use of a registry in which you can do that without having integration into other people and into health records, other health records. So shouldn't we be speaking the same language that every other healthcare provider when it comes to data integration? I think so. We've got the numbers. So Project Impact Immunizations showed recently they are the international award-winning program. FIP 2018 awarded them the Pharmacy Practice Improvement Program Award that showed that when pharmacists put together the data along with giving the immunizations, that the pharmacists who have bidirectional information and forecasting that says what the patient is due for, having a dialogue with the patient, there will be an increase in immunization rates. That was proven. So how many people in this room, by a show of hands, have ready access to their vaccine record on their phone? Okay. Is it official record from the state? I have one. Arizona has a product called MyIR. So let's focus a little bit on, in Arizona, there's a service that the Arizona IIS has called MyIR. And I have a shot record on the state. It is the official record of the state. So if I need a copy of it, I can print it out, and it has a little barcode and it says the state of Arizona, which is really nice. And I could give that at a point of care to a patient if they didn't have any apps on their phone, didn't want it, or just needed the information. But for us to have robust information, we need to have all immunizers reporting. And so one of the things I'm really going to advocate for today is that instead of saying, well, the doctors have to report, and I've been in many meetings where they're going to say, no, I'm too busy. I think one of the things we need to do is do a little thinking shift and talk about all electronic health records, all pharmacy management systems, et cetera, should be required and be electronically equipped to push immunization information to their state IIS. Take the burden off the providers, make it a burden of the software that they're using because they have the capability of doing it. So I'm going to show you real quick. So this immunization record is what kind of pops up on my IR, on my phone. I don't really want you to focus on that one, but my schedule. This is my forecast. So what am I due for? So I'm probably overdue for my, I'm past due for zoster. I haven't had a chance to get to the doctor, right? And I'm a healthcare provider and an immunizer. Not behind, right? But I did have a zoster shot a few years ago. Anyway, what's the value to me personally, just as a person? Besides knowing what is due and when it's due, I have fractionated healthcare. I go to many different places for my healthcare. I have a certain insurance company. I go to the base. They refer me to outside providers. I go to the VA for other things. I may go to the pharmacy to get my shot record. I'm fractionated, but I'm healthcare savvy, I think, in terms of keeping that information. What about the average person? What about mom who's got 3 kids? How does she manage that information? How does that, your kid's going off to college. Where do you get that record? How do you get that information? So having that information that's available, knowing when the shots are due is just invaluable, not only to the pharmacist or any kind of immunizer, but to the patients and the people who would be concerned about it. What's the value for having a shot record, a mom with a family? Outside of a flu shot, when's the last time an adult remembered when they got their last Tdap? How many people in the room remember when they got their last Tdap? And we're healthcare immunizers, right? Just great. I can't remember necessarily what I had for lunch 3 days ago, never mind when I got my Tdap. And most people don't even think about it. Geo-mapping. This is another one of my favorites. So we have the capability. This is a blank thing. Every day I turn on my computer and I look at the world to see what's happening out there, what suddenly is going on. But you can have geo-mapping for your state. You could have it for your county. You could have it for your store catchment area of who your community is. And with robust registries, you could potentially see troubled spots. So this could be a tremendous benefit to health departments. They know that a measles outbreak is coming, and they log on their GIS mapping, and they look to see visually the dark spots, all the dots of who's immunized. And they can see very quickly in different counties, well, in this county, we have low immunization rates. We need to start a campaign in those counties. Who's there? Who's the workforce that's in that county? They're pharmacists, right? It's not to say the pharmacists alone are going to solve the problem, but there's probably not enough healthcare providers in those communities. You have to do it as a whole collective group, but you would be poised to work on it. So pharmacies armed with the same information or in partnership with health departments can engage in immunization campaigns that can thwart pandemics or epidemics. We want to utilize and build upon these technologies as they become available, but also utilize them on other types of prevention and patient care activities. So based on some of the IIS platforms that are out there right now, we can manage point of care testing that's available. We can have access to patient information in terms of patient education, diabetes management, other things in there that we could put on a registry, which would be easy for a physician to log into, to look at with the patients. It depends on the state if it's opt-in or opt-out. But you could have providers wherever this patient goes, if they have fractionated healthcare the way I do, to look to see what's going on with the patient. You did an intervention in the pharmacy, you don't have to track down the physician, you don't have to fax it to their office, they can't say that they never received it. It puts it in a really sweet spot. So I'm going to end with this slide, and then I really want to open it up to a good dialogue. So today I hope that I challenged you a little bit to think about the status quo. I want you to strongly consider and challenge you to think that I'd like you to accept and support our future as population health partners. We should be advocating for pharmacists as population health partners. We should be leveraging population health data to support areas of unmet health needs related to prevention, and we went through the 3 types. We should advocate for legislation at the state level for all immunizers to report. Don't make it just a pharmacy thing, make it for all. And leverage new connectivities as they're available. So if we as the pharmacy profession stand as population health partners, you'll find, as Glinda, the good witch from the Wizard of Oz, stated, you've always had the power, so let's use it. Thank you, and I'm going to open it up for questions. And
Hi, I got a question. I was looking at my IR. It only covers 4 states right now. How long have they taken to get to 4, and what's the prognosis? This goes to your 3rd bullet point of getting more on board.
so the first thing is that all providers should be reporting to an IIS, and they don't because they're not required to. Just the mostly pediatricians who use the Vaccine for Children program and pharmacists that require it in their state Practice Act. So we've got good information on the immunizations, the flu shots that we've put in there, but I think medicine's really not, adult medicine is not really set up for looking at immunizations. They have to meet it in their HEDIS measures or whatever their STAR performance measures are, but it's kind of an afterthought. It's not in their workflow, it's not in their training, it's not really in their thought process. And a lot of doctors just say, go to the pharmacy and get the shot. But it's not necessarily, that data is not entered if it was even given in their office, if they even carry that stuff. So that's the first thing, is get it in the IIS. Every state has an IIS. About 30 of them have bi-direction. Yes, sir.
I'm just curious, in the states where pharmacists are required to report, or pharmacies, has there been data, or has there been any look at whether that serves as a deterrent to pharmacists immunizing?
No.
Is there any difference in immunization rates in states where pharmacists are required to report versus where they don't, or not required to report?
That's a good question. I'm going to ask Ben to comment on Washington State because he just completed the immunization project.
So in the work that we did in the impact immunizations pilot in Washington State, one of the reasons why we chose Washington State is because the registry is one of the most complete in the U.S. And the opportunity that we have and what we're seeing is that in the states where the practice acts require pharmacists to report, that those registries incrementally year over year over year are becoming more and more complete. And that's a big help to everybody, because then when any provider accesses that data and tries to identify unmet needs for people, the relative level of completeness is much higher. And so it helps with that forecasting, and it helps everybody who's accessing that record as a collaborative team, if you will, to be in a position to know what the best thing to do for each patient is. So almost on the flip side of your question, we're actually seeing it as a really empowering kind of a circumstance when pharmacists are actually reporting into the registry on a consistent basis, and it's a good thing and it's a positive thing. The issue that we have today is that really only 34 states as of a few weeks ago were in the bi-directional registry business. So that means that you can insert your vaccine record for a patient into them, and you can also receive the information back. And we need to get all 50 states to that level. And more importantly, probably the insanity associated with the notion that we have 50 different registries is also out there. And so the notion that, you know, these registries, to the Geo-Mapping point that Lisa made, could be, you know, integrated would be very useful. So imagine, to her example, that we had one oral health registry throughout the United States. would that be a good thing?
We have a question from our live audience. We actually have two. So the first question is, what are some of the reasons for low vaccination rates?
Good question. So I think the low vaccination rates pretty much in the United States for the past 30 years have been focused on children. They've had campaigns even longer than that, even starting in the 50s, where they had campaigns where it was really going to be focused on kids. And it still pretty much goes to that. And I think the perception of the public at large, along with how, as we discussed with the adult medicine, or how physicians are trained in adult medicine, they're not focused on immunizations. Pediatricians are, because they're working with young kids. But once they hit an age where they're not going back to see the pediatrician on their height and growth chart, and they've had their series, you know, after the age of 5, maybe you don't go back for a booster for, you know, you need a couple boosters, but that's about it. By and large, unless you need a physical somewhere, and they may go to urgent care for that, nobody's really focusing on it. So that really is. And so adults, like I said, who remembers the last time they had a Tdap? Never mind anything else. You know, usually it's out of sight, out of mind. People aren't even thinking about it. So that's really our opportunity to create awareness, particularly in adults, or from, you know, like I said, the 18 to 65-year-olds, that where we can have an impact and really help to grow those rates. And it keeps the overall population healthy, back to that herd immunity slide.
The second question on live is, what technologies are most helpful in doing vaccinations correctly?
So I think that the technology that's most available is obviously most pharmacists can be working whatever their pharmacy management system is, but that they have a connectivity to the state IIS, and that technology is available. There's several programs that already do that. I think having the bidirectional piece in terms of being able to enter the data in and being able to see the data back, having connectivity to the patient, so the patient has an awareness of what it is that they need or have. There's a phone app. I know that there might be 1 or 2 phone apps out there where a person just on their own can enter their own immunization information, but that's not an official record. I think something like the model in Arizona with the MyIR, where it is the official record, really becomes important. And that's based on the information that was entered into the system. So that way, at least you know it's accurate. It may not be as up to date, or, you know, depending on who the immunizers were. So I think it's a public perception, it's a medicine perception, it's a, you know, a patient awareness, it's a pharmacist awareness. I think it's just an overall level that we need to raise up in terms of awareness. Yes.
I found it really interesting. It's the first time I ever heard about population health and CDC saying that the collaboration is so important. And it made me think that, at least what I'm aware of, most pharmacies and pharmacists have been going at collaborative agreements to go to a clinic or an individual physician who may or see them as competition for
Yep.
some of their claims. And what a great opportunity to be able to go to either local departments of health or state
Exactly.
departments of health and offer them, who don't have the money to do it and who need the assistance, but to start with some type of collaborative arrangement with the state.
Exactly.
And then gain even more credibility, so that those clinics and individual physicians are like, wait, this can help and not hurt.
Thank you. That's the point I kind of wanted to make. I wanted Amanda to comment too, because she's working with a couple different health departments.
Yeah, and what we've found by and large in the state of Kansas.
I'm sorry, tell her where you're at.
Yeah, so in the state of Kansas, we work with, our pharmacies are in the Kansas City metropolitan area. So we span, I think, about 7 to 9 different counties. And we work with a handful of the state departments of health in the area, and the local county health. And they have just been delighted to work with pharmacists and pharmacies, and looking at, you know, here's this population of healthcare providers that we've never worked with before. and just thinking of all of the different ideas that they can do and work on projects with us. A handful of their grants require them to do outreach to providers that are not physicians. And so we've been able to work our way into several different grants related to things like disease prevention and disease care. So it's been, public health is excited to work with the pharmacy community, and we just need to be those ones to reaching out to those in that area.
And I'll just add one other comment to that. So in the case that I gave of where a patient came in with flu-like symptoms, if you had a protocol in place with your health department, whether it's local, state, right, and they have a medical director, all of them do, who signs off on that protocol, you don't have to deal with, even the local collaborative. That's your collaborative practice, is you're working with the state health officer who can help address, public health issues. Because if they're having a pandemic of flu, they need to be treating it. And they don't have the workforce to deal with it. And the ERs are overloaded and it's expensive and we're not. So, I mean, that's just a great example, depending on how your state's set up. But I would really, really encourage everybody in their states to start working with their health departments.
Lisa, thank you so much. That was really a great presentation. This is just more of a comment to help spread the wealth. There are a number of resources for pharmacists that have been put out by the CDC. So there is one on community clinical linkages that provides guidance on how pharmacists can become more connected into their public health departments. And there are several on screenings, for instance, for hypertension and using the pharmacist patient care process. So if you just Google pharmacist and CDC, you'll see that they are very committed to involving pharmacists in a number of public health activities. So really appreciate the presentation.
Thanks, Ann.
Comment. I'm Nikki Hilliard from Arkansas, and found out that healthcare providers, including pharmacists, can provide the fluoride sealants for children, and they will pay for it. The state will pay for it, and so it's a revenue stream for the pharmacies. And dentists, I talked to my dentist, and he said he would be even glad to help train pharmacists to do that, because it's such a need, and there's such a lack of dental coverage and things. So I think that's one of the, another area we could involve in public health. Another comment I was going to make that I went to a presentation by Trent Haygood, who is a medical director of Blue Cross Blue Shield nationally, and he was presenting this database that they have full of claims data, not only Blue Cross Blue Shield, but I think Medicare and Medicaid as well. And they could pinpoint the social determinants of health by zip code. And he talked about, I talked to him afterwards, and he talked about even each pharmacy, coverage area, they could hone in on all kinds of health data, and they had that information available. So, and I'm sure they're working on getting that out, but it was a fascinating resource that might be available for us.
So just to that comment, that's good data that they have. The social determinants of health, particularly in an underserved community, is obviously there's going to be more health disparities. And I don't know that Blue Cross Blue Shield wants to readily share their proprietary data. But I think that also the health departments pretty much know where the unmet need is too. That's what they do.
Lisa,
Yeah.
thank you for all this great information. I appreciate you enlightening us today. I would like to ask your opinion or your thoughts on the new millennium moms not wanting to immunize their children. My daughter.
Thank you.
My daughter works with a lot of the new moms, and their thought process is that although these disease states are eradicated and their children do not need vaccinations.
You just have to go back to, there you go. You don't even have to say anything. You could just show this to someone. You have unimmunized children, they go to school? One of the pediatricians, he was an infectious disease pediatrician that I worked with for years in the Indian Health Service. He said, children are little bioterrorists. They don't mean to be, but they are. If you've ever had a child that goes to daycare, you've never been so sick in your life. I mean, you may deal with patients all day long, you know, in a hospital environment, in a pharmacy environment, in a community environment. Your kid goes to school, and suddenly everybody in the house is like, has dreadful, you know, colds, flu, everything else. So they're little bioterrorists. So for those people who don't want to immunize their children, are they sending them? There's reasons why children don't get immunized. I mean, if they are immunosuppressed or they're going through certain types of therapies, just like adults. But I mean, part of the whole population health, public health piece is to try to protect those folks who can't be immunized. Not that they won't be immunized, because even still, if you have like the case of like the second group, right? You have just a few kids who go to school who are immunized and other kids who are not, and measles comes to town, which it is, they're all going to be impacted. Versus on the third section, where if everybody is already immunized against measles, maybe a few kids will get it, but pretty much the whole group won't. Even those who are not immunized, because the herd immunity, 80% or more of the people around them are immunized, so they can't spread it. I'm not going to get into like the reasons why, but I would show them the slide. Okay.
Just to follow up on that, I've had some conversations with some of those people, and I think their focus is on what they perceive to be the risks of the vaccine.
Right.
And so they're ignoring the risks of not vaccinating the children.
Mm-hmm.
And so I think if you can steer the conversation towards risk versus benefit, and you have to get them to look at both sides of the equation, the risk of vaccinating versus the risk of not vaccinating. And this slide is part of the issue, the fact that if they don't vaccinate their child, they're exposing them to the disease. And a lot of them don't realize that their child could get the disease in the era when we have world travel and people getting on planes and spreading diseases that previously they've never encountered before. And secondly, these diseases are dangerous. People die from these diseases, measles, mumps. The millennials, for the most part, don't understand the risks of the diseases,
right,
and that they can cause deafness, sterility, death. I mean, serious permanent injury and so on. And of course, as you know, the risks are vastly overstated and based on myths and so on, which you don't really even need to get into some of those discussions with these people. You just need to get them to understand that the risk of the vaccine are more theoretical, whereas the risk of not vaccinating the kids are very real and very dangerous. And they really have to think about the risk of not vaccinating and get them to understand that they're really exposing their child to serious risk if they don't do it.
Yeah, how many people were alive in the 50s? I remember people who've had polio, measles, mumps, chickenpox. I mean, it was people we knew. Some were injured by it severely.
This is a fantastic slide. I would ask if APHA could post this, and that the foundation would post this, and that we would be able to like it on Facebook, share it on Facebook, put it on Twitter, wherever, because I think this graphically is just a great picture for those people who are afraid.
Yes.
So I'm going to switch gears a little bit. There's been a lot of conversations on population health and how pharmacists can be really involved in population health management. To me, I'm a little bit confused between the differences between public health and population health. So I'm wondering if you can comment on maybe the similarities or differences between the two terms.
Okay, so public health really works to make sure that the population is healthy. And usually the lowest hanging fruit is prevention, the primary prevention, immunization, secondary prevention, tertiary prevention. That's the prevention strategy. But overall, population health and how it's being spelled out by the CDC, by Institute of Health, by Institute of Medicine, is really working for getting better outcomes and collaborating to make sure that all those public health pieces are done. So we have a population that has healthy outcomes. Does that make sense?
So you're saying that population health is more focusing on the collaborative efforts to kind of achieve public health?
It can be, so part of the strategies, yes, or collaboration, non-traditional partnerships, but looking at outcomes. So if the outcome is not just that we, in prevention, we give a shot, we prevent a disease. The outcome would be, did you actually measure it, and how many people did you give the immunizations to? And then, so what's our coverage rate for this population? Yes.
I'm also about to switch gears a little bit. So as a student pharmacist, I'm lucky enough to be able to immunize in Florida after my first year of pharmacy school. But there's a lot of states out, well, not a lot, but there's a few states out there where students still cannot immunize. I know you've been an advocate over the years of pushing through legislation to allow pharmacists to immunize. What's your advice for those students in states where they can't immunize? How can they be involved? Or how can they be involved in maybe pushing legislation through to help them immunize?
You know, your best partner would be your state health department. What is it in terms of what the need is in your community? Where are the gaps? How then would they have a workforce to do that? What's the student workforce that can help add to it? And I'm just going to put out there, in some states, they're talking about technicians can immunize. It doesn't take rocket science to learn how to immunize. So it's just a matter of the pharmacist could assess the patient, could assess their medications, their profile, everything else, but the actual giving of a shot can be done by a technician. I mean, medical assistants in doctor's offices give shots. How often does a doctor actually give an immunization? Like never, hardly ever, unless they're doing something, you know, right in the ER or something. So do a little research. And then it's also kind of, I won't get into the legislative pieces of what the politics are in your state, because I'm not familiar with it, but you know, but I think if you arm yourself with your data in terms of what it is, maybe looking on your IIS, what the need is, what the unmet need is, what are the vaccination rates in your state, who is it that you want to target? Is it target college-age students in your health center? Meningitis, Hep B, just whatever.
All right, I'd like to thank Captain Lisa Tonrey for her lecture. For those of you that are here and tuning in, this lecture will be available on the APHA Foundation Facebook page. Thank you for joining us today and enjoy the rest of your day.
Thank you.